I'm an interventional cardiologist at MonashHeart, and I'm also the co-director for cardiac CT service at Monash, and I run the service along with my colleague radiologist Dr. John Truipis. Monash cardiac CT service was started, as I mentioned, in 2008 with the 320 slice CT scanner, which was the first such scanner in the Southern Hemisphere at the time. We have a very busy clinical program. We're the busiest center in Australasia for cardiac CT, which include an acute chest pain program, structural heart disease program, and pediatric and adult congenital program. We are also the most well-known research center for cardiac CT in Australasia. We have excellent research output, which includes both single center studies and also participation in international multi-center trials. We are also one of the leading providers of CT education to both cardiologists and radiologists in Australia and New Zealand. So we are very proud to have an excellent service at MonashHeart. MonashHeart has had a long relationship with Toshiba, dating back many years, starting in cath labs and in more recent times, particularly with cardiac CT. Our center was fortunate to be the first Southern Hemisphere hospital to have a 320 slice CT scan at the time, and we've pretty much grown significantly ever since with our research partnership. It's gone from simple validation studies looking at accuracy of 320 slice scanners to more complicated CT perfusion and FFR, iterative reconstruction, transluminant attenuation gradient, and more recently CT FFR, and also we're looking at vulnerable plaque, pericardial fat, and a number of other projects. And I have to admit that the collaboration, the partnership has been outstanding, and I believe it's been mutually beneficial to both parties. Cardiac CT is a very good anatomical test. It correlates well with invasive angiography, and in addition, when you compare it with other non-invasive techniques, it identifies more than 50% stenosis, usually much better than the other non-invasive techniques. However, as we also know that the current gold standard to decide which lesions need to be revascularized is not anatomy, but fractional flow reserve, which is the current gold standard. So the ideal the solution should be to come up with the anatomical test, which cardiac CT is excellent at, as well as providing an answer which resembles fractional flow reserve. The problem with the cardiac CT is, as we all know, it's got very high sensitivity and hence very high negative predictive value. However, if you look at 50% or more stenosis on cardiac CT and compare that with the fractional flow reserve, only about half of the 50% and above stenosis identified on CT will turn out to be FFR significant. So therefore, it's really important that we not only provide anatomy, but also come up with a value which resembles FFR. So to try and provide not only anatomy but also function, there have been three main techniques which have evolved over time. First to come up with was CT perfusion, which is essentially repeating the cardiac CT with a stress agent, and this of course requires extra time, radiation and contrast, and even more importantly, it requires expert interpretation. And however, there is a number of trials and large body of data supporting this technique. Another technique to evolve is what we call transluminal attenuation gradient, or TAG, which is looking at the drop of Hounsfield unit along coronary vessel. Initial trials have been very promising, but subsequent trials have been with variable results. And more recently, data suggests that perhaps this may also be a function of the vessel diameter than actual stenosis. So more studies need to be done on this technique. CT FFR was developed by a company called HeartFlow. This uses resting CTA, and using a method called computational fluid dynamics is able to derive fractional flow reserve along the coronary tree. However, in this model, the images need to be sent away, and the processing requires both human input and a supercomputer. at a cost. So therefore, the current research that we've been doing is to look at a simpler technique which can be done at your CT practice, rather than requiring images to be sent away and requiring a supercomputer. And that's what the emphasis has been in our research trials. Toshiba CT-FFR the software is different to HeartFlow. It's starting from acquisition. It requires only a REST study. However, the REST study requires a wider window, so it requires 70 to 99% exposure. And once the images are acquired, then the anatomical modeling allows the vessels to be assessed up to a diameter of 1.8 millimeters. And boundary conditions in this particular technique are derived by looking at cross-sectional area changes in coronary arteries and adjacent aorta. Very important difference in addition is the numerical solution, or rather than a 3D solution that is used by HeartFlow. Toshiba CT-FFR uses a single or reduced order model. This allows the assessment of FFR to be done on a desktop with about 20 to 30 minutes reading time, and this can in fact be done by the technologist, and therefore requires relatively little amount of training and is highly reproducible. So it's got significant advantages, provided that we can continue to show that results are consistent in a larger cohort. The MonashHeart CT-FFR results was published in JACC Imaging recently. Primary author of the study was Dr. Brian Coe from our center. We used 42 patients and eventually looking at 58 vessels, and these were patients presenting to our center for investigation of chest pain, and the gold standard was fractional flow reserve. To keep the integrity of the data, we used different collabs. So for CT, collab was Nintendo Japan. FFR collab was MonashHeart, and CT-FFR values were assessed by Toshiba in Japan. What we found is that this technique is able to significantly improve positive predictive value and specificity without compromising the sensitivity and negative predictive value. This is what we expected, but therefore it's a very pleasing result. Of course, this is a single center study and relatively small sample. Therefore, we do need to have more data to prove its value, but initial results are extremely promising. CT-FFR is a very important addition to the current knowledge base because, as we discussed, cardiac CT is very good at excluding FFR significant lesions, but the problem has been to identify which lesions require revascularization. So this provides an excellent opportunity to assess which lesions need revascularization non-invasively, and very importantly, this particular way of doing it allows us to assess vessels at your own practice, possibly even using CT technologist, and to be done within 20 to 30 minutes on a standard desktop computer without requiring images to be sent away. So that is the most significant advantage, and that could potentially significantly change how we practice cardiac CT.